Welcome to Health Talk. We're so excited today. We're going to talk about hernia surgery, and we have with us Dr. MarcZareMD, who is a board-certified general surgeon and also fellowship trained in minimally invasive surgery and laparoscopic surgery. Also with us, we have Dr. Mary Rithri-Varkey, who is going to ask questions about what her patients who would see an internist might ask about hernia surgery. So, hernia surgery is the most common elective surgery for general surgeons. Is that correct?
That's correct, Larry.
And in your practice, how many patients call you about hernia surgery a week?
Oh, we have nearly a full dedicated day of hernia surgery every week as far as what we perform. And seeing new patients, there's not a day that goes by where we don't see new hernia patients.
So hernias, for the home audience, what is a hernia to a general surgeon?
So good question. So hernia is a simple concept to understand because we all know what a tear looks like, what a hole looks like. A hernia is nothing but a tear or defect or a hole within the wall of a cavity. So that cavity that we are most commonly referring to is abdominal cavity. And so a hernia would be essentially where any part of the muscle that holds our abdominal cavity together has a hole or a defect within that, and things then bulge and protrude through that, and that's a hernia.
So the most common surgery for hernias for general surgeons, inguinal hernia. So for inguinal hernia, explain to us in the home audience, what does that mean, inguinal hernia?
So inguinal hernia is also commonly referred to as groin hernia.
Groin hernia,
yes. So it's essentially a hernia that occurs within the groin muscles, and it's by far the most common type of hernia that one can see in our practice. It tends to be more common in men, and there are a couple of different types of inguinal hernia one can get. To get not too technical, there's the direct and indirect. Essentially, one is understood to be a tear in the muscles of the groin, and the other more of a congenital acquired a defect that can present itself anywhere in childhood all the way to adulthood.
So when people have these hernias, what would they typically say to the doctor? And then when would they seek you?
So ideally, we like to see patients as they develop the hernia and as they're being diagnosed in the early phase. The reason is the hernias get bigger with time. We know that based on 200 years of dealing with hernias and seeing them progress. So that's a natural history of a hernia. We have to all really start with that and understand that. Knowing then that hernias can get larger with time then paves the way to come up with a clinical treatment plan. Some patients, of course, are not in the best of shape, advanced age, medical conditions that prohibit surgery. Those should be really the exception. Majority of hernia patients are fit to undergo surgery. They just may not receive the right recommendation or referral for a hernia repair. So in our surgical world, we know that hernias get larger with time, and as far as repair of a hernia, they get more complicated and lengthier to perform if they're presenting late. So I'm always eager to perform a hernia surgery at its early stage, just because patients' recovery is also easier.
So you were talking about the complications of the hernia. So you said the hernia gets complicated. So can you just explain for the home audience what the complications are, doctor?
Sure. So when you haven't yet received surgery for hernias, the actual existence or life of a patient with a hernia is typically one that's limiting lifestyle perhaps or activities. Patients oftentimes don't exercise as much as they would like to because of the interference of a bulge. They may experience pain, and obviously as a result of that may miss work, they may miss exercise, they may miss day-to-day activities. Those are not quite complications, but they can influence quality of life. When you come to a little bit more more, I guess, medically significant things that can happen to a patient who still hasn't undergone hernia repair. Classically, we talk about strangulated bowel, which the easiest way to understand that is if you have a loop of bowel going through a small hole, if it's being pinched and the blood supply of that bowel is being compromised, then the bowel that's herniating through can die. And so that becomes an emergency and one that we would really like to avoid. Fortunately, that is a rare complication of a hernia.
So you want your patients to seek help before it goes to that stage?
Of course, yes. We want patients to really seek help with a hernia expert, a hernia surgeon, because outcomes of hernia repair are influenced by the experience and the approach of surgery. We want them to seek help early so that their operation is done on a small hernia, hopefully, and it's a shorter and easier procedure, both for the surgeon and especially for the patient to recover from. And of course, while you're receiving the care, you're avoiding future complications.
And how is the road to recovery after the surgery?
So specific to inguinal hernia repair, if you really have to sort of step back and look at the historic perspective here, because that really, I always start with telling patients how hernias used to be operated on, what the recovery was, and what it is today. It's interesting, I had a patient today who had his hernia repair done in 1960, and he remembered exactly what he went through. He had a large scar to show me, and he remembered that he spent 5 days in a hospital for an inguinal hernia repair, something that is really quite rare or unheard of in today's medicine. So in the olden days, hernia repairs were done using an open approach, which meant that the incision was at least 3-4 inches long. It was painful, and as a result, patients would come in the day before and spend a few days in the hospital and spend up to 6 weeks recovering from just having had a hernia repair. A seismic change that occurred for us was in the mid-1980s. Actually, down in Southern California, there was one of the first surgeons who proposed the idea of performing a tension-free hernia repair, which was in contrast to the older techniques where your own native tissue was used to bridge the gap where hernia occurred. Surgeons would suture tissue over and try to kind of bridge the gap and fix the hernia that way. Part of the reason that procedure, the olden technique, was very painful was because of the tension that was placed on the tissues. But more importantly, that older technique was associated with a high recurrence rate, as high as 30 to 40% of patients who had open tissue repair or anatomic repair would end up with yet another hernia, which is why I had my patient today in my office. His hernia has now recurred. So the change I was referring to was in the mid-80s when the tension-free repair came into consciousness, and that's when use of a prosthetic mesh became the standard of care so that we can reduce chance of recurrence of a hernia and be able to also minimize pain. And of course, along those lines, the next big step in hernia surgery was in the early 90s when we introduced laparoscopic surgery, and that was a giant leap again because not only we were using a tension-free concept and having less pain as a result of that, we almost got rid of that big incision that went through layers and layers and used a laparoscopic or minimally invasive approach to that operation, and I can expand on that. So laparoscopic surgery is a concept. Is where we can avoid big incisions and get into the cavity of interest with very small incisions. If you look at the model I have here next to me, this is a model of an abdominal cavity, and so you just have to use your imagination, groin being at the other end and having a hernia sticking through the abdominal muscles. Instead of making an incision and gaining access to the hernia site, we can place trocars or plastic sheets that are even smaller than what you see here sometimes. And with 2 or 3 of them, we can gain access via a telescope and long instruments such as this, and gain access to the area of interest, perform the whole operation without opening the muscles, and essentially repair the hernia without having done the classic cut and sew technology, which is part of the reason patients have pain.
So I believe with the laparoscopic approach, the complications are very minimal, the post-operative complications.
Yes. So the best way to think about laparoscopic groin hernia surgery versus open groin hernia surgery is really done to help patients get back to their day-to-day activities and get back to work and have the minimal impact as far as pain and the stress of surgery is concerned. It is not so much because it's safer or has fewer complications that we offer the laparoscopic approach, and it's not really so much because it's more effective. In other words, both laparoscopic and open hernia repair, when done by an expert, should be very safe and should be very effective. It's really in the recovery that we can influence patients' experience. So what we typically see and tell patients is if you have open repair, you are going to be hurting for about a week and probably not returning to exercise and heavy lifting for 6 weeks. Now, if you contrast that to laparoscopy, it's about 1 or 2 days of discomfort versus 1 week, and 1 week of not heavy lifting versus 6 weeks. That's where the difference comes in.
So after the surgery, after they have got their laparoscopic or open surgery for their hernia, so is there anything they should keep in mind throughout their life, like lifting heavy weights, or some patients tell, like, can they be normal, like what they used to be before?
Yes, so the long term is they can be normal. They can go back to everything they like doing. In the short term, to allow tissues heal, for laparoscopy, we would like for patients to take it easy and not lift more than 20 pounds in the first 1 or 2 weeks. The limitation is much shorter than for open, compared to open, which is 6 weeks long.
Now, the other types of hernia surgery that general surgeons also do are ventral and umbilical. Now, pregnant women get this. Tell us a little bit about how common are these?
So umbilical hernia and hernias around the belly button, if you can imagine the middle of the abdominal wall in the center where the two muscles, the rectus muscles, are coming together, that entire line called linea alba is a potential weakness for hernias, especially in a setting like a pregnant mother or repeated pregnancy. This stretching of the abdominal wall can cause hernias, most notably in the umbilical area, or sometimes right above it, where we call it a supra-umbilical hernia, or sometimes below it. A lot of patients have had prior operations, so they have a scar or incision in the middle, and so any kind of stress like pregnancy or even otherwise can cause hernias within that incision. So we call those incisional ventral hernias. They all fall into sort of the same concept, same category of hernias on the front of the abdomen, and they're very, very common, actually.
So are those hernias, do people still wait, or they come more quickly to you?
We've seen both. Today, again, I saw a patient who had an umbilical hernia, but he was seeing me for a different condition, and he did not even know he had an umbilical hernia. And so I had to really educate him about the umbilical hernia, and he's so used to having that very small hernia, and it's not causing pain, that he had never been made aware of it. So there are those patients, small hernias, not symptomatic, and patients or their doctors are not really aware of them. Most of the other hernias, ventral hernias, or patients who develop a hernia in an incision, tend to have symptoms. They have bulges they don't like, they have discomfort as things bulge through the hernia, and so they tend to seek help.
So the ventral and the umbilical hernias, as you were explaining, so how are they treated? Like, are they laparoscopically done too, like the other inguinal hernias?
Correct. So they have, we have options, just like with inguinal hernia repair. There's always an option of laparoscopic and open repair. I think it's well accepted in our surgical societies that the application of laparoscopy and minimally invasive technology per se for example, a small umbilical hernia perhaps doesn't make sense because the hernia is small, can be repaired through a very small incision. Therefore, a laparoscopic approach coming from the side with 3 incisions perhaps wouldn't make much sense. Once you have larger hernias on the front, ventral hernias, incisional hernias, then we have to educate patients about the 2 options, pros and cons, and have them make a decision. A lot of this, again, smaller of the ventral hernias tend to be done open. Larger ones, the challenge with a large hernia in this area is that sometimes you need a sort of medialization or bringing the tissues back to the middle that have been retracted to the side, and that by definition a lot of times it's an open procedure. So in this specific subcategories of hernias, I tend to find open approach somewhat more useful.
So hernias occur to all ages, and I'm sure that there's also the hiatal hernia, which is common after pregnancy as well, or people who've had many children and the diaphragmatic muscle is bad, and then the stomach kind of pops up on you and get heartburn. How common is that in your practice?
So that's very, very common, and we don't really understand the true incidence of or prevalence of the hiatal hernias because in a lot of instances they are silent, and because maybe I should explain what they are. A hiatal hernia is not a hernia you can see on the outside of the abdominal wall, and because of that, patients typically don't even know they have it until they're in the later part of their life cycle. So what you're referring to is a diaphragmatic or hiatal hernia, which occurs within the diaphragm muscle, which is a muscle that goes across the top portion of the abdomen below the lungs and the heart, and naturally has certain openings in it for passage of important organs like esophagus and aorta. And these openings are typically very small. They are typically an inch and a half in diameter. But when they get enlarged for any reason, pregnancy being one of them, excess weight, bend in the spines, for example, kyphosis, scoliosis, different conditions where the spine's not quite straight, puts strain on the muscles of the diaphragm and stretches these openings. Now you have a muscle that's going across the top portion of the abdomen with a hernia in it, an opening in it that can be the trap where stomach or other organs get pushed through from the abdomen into the chest. And most common type of a diaphragmatic hernia is called a hiatal hernia. We see that in patients who typically complain of heartburn because the stomach is being pushed up into the chest cavity, and it can really influence quality of life and cause complications.
So if the patient has heartburns for a long time and if it is not, medically treated or it's not being able to be treated, so then they should think about hiatal hernia. That's what.
Yes, absolutely. So the doctors and the patients should really consider some sort of investigation for someone who has chronic heartburn. You can have chronic heartburn without a hiatal hernia, but in at least half of those patients, there is a condition that can be surgically corrected and hopefully prevent heartburn. Ways to identify that is typically with either an X-ray or an upper endoscopy that helps not only see the hernia but also see the anatomy from inside and see if acid reflux has caused any damage.
So that's when they should be seeing you once they get the reports.
Correct. We help them get the investigation, get an upper endoscopy if they've never had it. We help them get the X-rays, and then depending on the size of the hernia, we devise the plan. Typically, the repair of a hiatal hernia is, again, through a laparoscopic, minimally invasive approach. We use a robotic technology for that. Very helpful because the robotic instrumentation, which looks something like this, has the tip has certain capabilities that helps mimic the wrist of a surgeon, and so having technology like this really helps us repair a hernia and get the patient home the next day.
So they can post-operatively and pre-operative, what are the things they should follow for the repair? the
So,
diet?
ahead of surgery is all about coming up with the right diagnosis, identifying the size of the hernia and so on. If there's any damage from acid reflux, we make sure that it's treated with medications to suppress acid. But once the hernia is repaired, they're on a specific diet. That's the main thing to be aware of. Because of the repair and bringing the stomach and wrapping everything, patients are on a specific modified liquid diet and then gradually advance on a puree diet. But within a few weeks, they're eating food without the heartburn, which is what the goal of the procedure is.
So for all these hernia procedures, is the post-op recovery about the same, like less than a day inside the hospital?
Not quite. So depending on the kind of surgery, one can give some very, very reliable general predictions of recovery. For inguinal hernia repair, patients are not even staying in the hospital. It's an outpatient procedure. They go home right after, and within, typically a laparoscopic inguinal hernia patient within a day does not require pain medications. Within two or 3 days, they're back to work. And within 7 to 10 days, they are back to full exercise with no limitations. Now you take the ventral and umbilical hernia, because sometimes we place mesh and repair those, but they're so central and everything we do, and you use core muscles, they do take slightly longer time, up to 1 or 2 weeks of recovery. With hiatal hernia repairs, the last one we just touched on, the outside incisions are very small, they hardly ever hurt, but because we've done more work than just repairing a muscle, and we've actually brought stomach down, we handle organs, the recovery as far as being able to eat a full meal and being back to 100% normal might take longer, but the physical recovery is still fairly short, within a few days.
So after the hiatal hernia repair, should they take care of their diet and things in the late future, like avoid anything like spicy foods or anything that the patient wants to know?
So correct. So typically patients, before they fix the hernia, they have all kinds of difficulties with spicy food, acidic food. They have heartburn. They take medications for that. The goal of surgery is to really bring them to a normal lifestyle and eating style. And so once the healing is in place, I would say 2 months after surgery, patients typically can enjoy spicy food if they would like to, and even come off the medications that they used to take, sometimes for decades, to prevent acid reflux. Correct.
So show us, for hernia surgery, how would you use minimally invasive surgical techniques? You have a model there.
Yes, so for laparoscopic inguinal hernia surgery, for example, I make 3 incisions below the belly button. So you have to sort of use your imagination. If the belly button is somewhere in the middle, these trocars would be all in a straight line. We gain access to the space right underneath the groin muscles, the space called the preperitoneal space. And within that space, we start by identifying the anatomy and sort of use the camera to look inside and identify where the muscles are, where the defect, the hernia is, the vessels, and so on. Once that's done, and the hernia is well defined, content that's protruding through the hernia is pushed back to where it belongs, then we actually repair it by introducing a prosthetic mesh that's then secured under the muscle. The securement of the mesh is typically in these days done with very small screws that are biodegradable. So these screws are not metal any longer, and so you're really left with just a very light mesh that allows ingrowth of tissue. And a very common question I get asked is, how safe is use of mesh, right? And so in over 1 million of these hernias that are being done every year, the study after study has shown that if the mesh that's been FDA approved for hernia repairs done is used for the indication, which is hernia repair, and is done in the ways that I described, it's an extremely safe option, and it really has made a huge impact in reducing chance of hernias recurring. So it's really a very useful addition to our abilities. But sometimes surgeons use mesh for non-hernia operations and lifting pelvic organs that may be protruding or collapsing via the pelvic weak muscles of the pelvic floor and other conditions. And so that has given mesh sort of a bad reputation, but as a concept, FDA or surgical societies in the past 3 decades have never had a problem with the concept, and so we continue to offer that.
So we're coming towards the end of the show. Thank you for joining us on this very interesting topic, hernia surgery, since it is the most common elective general surgery procedure done in America. And the take-home lesson for the home audience, if you have a hernia tugging, pulling, especially in the groin area, don't wait. Don't be anxious, because with minimally invasive techniques, the post-op recovery is no longer a week or 2 weeks. It's just a matter of days and hours, because you're discharged the same day. And the same thing for all the other hernias. Don't wait. See your primary care physician. Be aware of what new techniques here are available in America. And so if you're interested in this type of show, donate to KSAR TV. Thank you for joining us, everyone, and we hope to see you again.